Okay. Good afternoon, everyone. This is Chinin Chang from Taiwan. Today, I would like to share my experience about the clinical application for bone porcelain restoration. Okay, this is at 2000. The patient came to me with severe attrition, but by the time the bonding concept sounds so clear. So let's look at her intraoral photos. We can see all her posterior teeth have severe worn down, and her major concern is her upper front teeth. After the severe attrition, the teeth look very short and doesn't look very present for her. So she's looking for some treatment to rehab her occlusion and give her confidence back. But by the time, what we can offer for this case is we have to prepare all the teeth for full coverage crown. And to achieve better aesthetic result, the prosthesis we can offer is porcelain fused metal crown. This is a occlusal view after we prepare all the teeth. You can see how much tooth structure has been removed after teeth preparation. And this is a frontal view after we place a temporary bridge. The aesthetic looks nice, and the tooth proportion, the aesthetic is acceptable for the patient. So we will be able to process the final prosthesis. These are all porcelain fused to metal crowns. They look pretty nice. The patient is very happy about it. But after doing all the procedure, I just feel like I killed all her teeth. I feel so bad about it. So being a dentist for a long time, the major concern for me is how to offer a more conservative treatment for the patient and how to preserve more tissue for the patient. Because a lot of tissue, after we remove them, they will never come back. So the biomimetic principle is raised by Dr. Pascal McNee in 1999. His concern is the treatment we should offer for the patient should be able to preserve the natures for patients, and we're using some material which can provide proper strength for the patient's function, and we will be able to use the material a conservative way to achieve patient's function and aesthetic need. This case actually gave a lot of confidence for me to do the bonding restoration. The patient came with deep caries, and he had his tooth have cusp fracture on the palatal cusp. So after we remove all the cavities, and we just noticed the pulp is not exposed. But for the treatment plan we could offer for this patient years ago, we will need to do the intentional root canal treatment for this patient. And after that, in order to get enough furrow effect for the crown, we have to do a root canal, and we have to do the crown lengthening procedure to expose more tooth structure. So that need to involve a lot of treatment just for this tooth. But after we have more and more bonding concept build up, I decided to try the bone porcelain restoration for this patient. So what I did is I still do the pulp capping with glass enamel cement, and I reduced the height of the buccal cusp in order to cover the buccal cusp for this tooth and just remove more unsupportive tooth structure. And because there's a very minimum tooth structure remaining, so I decided to put a temporary crown for this patient and wait for a month or two. Luckily, the tooth have no symptom after this couple months. So I decided just go ahead and take impression. This is the picture on the left. You can see the huge block of porcelain onlay. And you can see that's how much tooth structure he had missing. And on the right side is after we cement the onlay on the tooth. The aesthetic was fine. That's my very early case. The patient is very happy about it. And the onlay has been in the mouth for more than years, still function okay. That's another case. As a patient come with a large amalgam restoration on this lower premolar. And also because the buccal cusp get very fragile, the buccal cusp fracture. So we remove all amalgam filling material and we did a little bit preparation, preserve the enamel, and also put a temporary crown to check the patient's symptom for a couple months. The patient had no symptom after those 2 months, and we decided to take impression and deliver the final onlay. It's very hard to tell which tooth is actually onlay because the porcelain onlay provide very good aesthetic result. And this is the X-ray we took after we cement the onlay at 2014, and the follow-up picture X-ray on 2016 and 2019, they all look pretty good. So the indication for bound porcelain restoration is we can use a lot of situations like root canal treatment tooth or the tooth with massive structure missing, or some teeth have severe attrition or erosion. We'll be able to use the remaining tooth structure and restore the tooth by the bonding porcelain. Cracked tooth, personally, I would like to try some cases with cracked tooth, but still some doctor doesn't really recommend it because the full coverage crown actually provide better protection for cracked tooth. And also I think it's related to how bad a cracked tooth syndrome is. If the cracked line gets pretty deep, the patient still have the symptom remaining, I think I will still go for the full coverage crown. But if the cracked line is not too bad and partially reduction can solve the problem, reduce the symptom, I will still go for the bound porcelain restoration. Advantage of doing bound porcelain restoration is basically we preserve a lot of tooth structure, and we also preserve the pulp tissue, just like the first 2 cases. We basically don't need a root canal. The patient have no symptom, but if you're doing a traditional prosthesis, you would definitely need a root canal treatment, and you can preserve pulp tissue. Also, we eliminate the surgical approach. Like that 2 cases, if we need to restore with a regular crown, a full coverage crown, we will need a surgical approach to do the crown lengthening procedure to save the tooth. So we actually eliminate this procedure, and as basically reach my expectation, we can be very conservative and preserve more tooth structure. And also the properties of the porcelain provide very good aesthetic result. But the some disadvantage of it is most of this kind of restoration, they are good for only single units. It's very difficult to do a bridge on this kind of restoration. And for some teeth have very bad discoloration, maybe from the caries or from the root canal treatment. It's very hard to cover the shade by the porcelain restoration and achieve the good result because they have very good translucency. So you can't really have good result by just putting a clear translucent porcelain restoration. And also it's very technique sensitive because we've been using a lot of different material. We have to deal with that. And the teeth preparation are very different from the traditional prosthesis. There's a lot of consideration about it. Also, there's isolation and the cementation procedure. They make this restoration become more complicated. So what are we dealing with when we're doing this procedure? We have to deal with the enamel, we have to deal with dentin, and we have to deal with adhesive and composite resin and the porcelain. So the following topics, I'm gonna go into the some topic about this bond porcelain procedure. I'm gonna talk about the material. I'm gonna talk about immediate dental sealing, which is a very important concept when you're doing the bond porcelain restoration. Also, the deep margin elevation, tooth preparation, impression taking, and temporization, isolation, and cementation. For the material we're gonna use for bond porcelain restoration, we actually started in 1999. Dr. Pascal used pathetic ceramics, and then comes out the lucite reinforced ceramics. And then the most popular material now is lithium disilicate ceramics. So most of the silicate-based ceramics, they are etchable. They can be bound with adhesive resin. So the pathetic ceramic, they actually have highest translucency, so they have very good aesthetic result. But they have not very good fragile strength. It's only from 60 megapascal up to 140. So you can see more value by using the ceramic. Then the Evoclear company comes out with a lucite reinforced ceramic, and they are composed by 60% of glass and with the lucite to increase the strength. So the fragile strength can go up to 80 to 140 megapascal. It's higher, but still not very good for the posterior teeth. And the way to fabricate that, you can use press ceramic or use CAD/CAM technique. And now they come up to the lithium disilicate glass ceramic. That's getting very popular now. They basically replace a lot of, they basically being used for most of the cases now. They have only 30% of glass and have 70% of lithium disilicate. So they highly increase the fragile strength up to 440 metacospa. And the way to fabricate it is also they have pressed ceramic, also use a CAD/CAM system. But compare these two kind of fabrication technique, the press techniques still have a higher compressed strength and fragile strength on that. Then let's talk about immediate dentin sealing. This is a very important concept when you're doing a bonding restoration. It means immediate application and polymerization of the dentin bonding agent to the freshly cut dentin prior to impression taking. So we would like to apply the primer and bonding agent just right after we cut the dentin. So we will be able to achieve better bonding result. The dentin bonding principle is basically create an interface or interfusion layer, which is called hybrid layer, as we basically penetrate the bonding monomer into the hard tissue, into the dentin. So once this infiltration resin is polymerized, it can generate a structure which is very similar to the dentin enamel junction. So give a very good strength to bond restoration on the dentin. So this is a picture just showing you how we do it after we cut the dentin and we age the dentin surface immediately and rinse out the agent. We apply the primer and bonding, and we apply the glycerin gel to block out the oxygen in the air and lacquer for 20 seconds. And when we apply the bonding agent, we can still essentially apply the bonding agent on the enamel surface. So what we need to do is we have to slightly prepare the enamel surface after we do the immediate dentin sealing procedure. The advantage of immediate dentin sealing is we can improve the bond strength, and we have fewer gap formation on the tooth surface. And after we seal the dentin, we decrease the bacterial leakage, and we can also reduce the dentin sensitivity. There's a lot of evidence shows that's an advantage of dentin bonding agent on immediate dentin sealing. So after we have the dentin freshly cut, it's very ideal for us to apply dentin bonding. When we procure the dentin bonding agent, we actually improve the bond strength to the highest. And after immediate dentin sealing, we allow a stress-free dentin bond development. We don't need to worry when we apply the bonding agent. When we deliver the porcelain, we might immediately create more stress on the tooth and restoration. And also immediate dentin sealing, basically we protect the dentin against the bacterial and micro leakage. And we can also reduce the sensitivity during the provisionalization and before we deliver the final restoration. But there's something, little tip you have to remember is when we're doing the polymerization, which means when we're doing lacquering for the bonding agent, we should do it incrementally to reduce the heat relief from the bonding procedure and might irritate the pulp tissue dentin. And if we remove the caries by the caliper or the hand instrument, we basically generate less smear layer, so we can use self-age adhesive. But if you remove the caries by using a high-speed diamond instrument, the total age technique is recommended. Also, when we take an impression on the tooth with the immediate dental sealing procedure, we should use PVC impression material because a polyether material actually bonds to the bonding agent on the dentin surface. So this is a photo we show you how to do the immediate dentin sealing. We do the isolation on all the teeth, and we apply the agent on the exposed dentin area. And rinse out the dentin, we apply the primer, and we slowly and gently blow dry the primer. And we apply the bonding agent, but we don't really use the air to thin the bonding agent. And then we apply glycerin gel to block the air, and then we do the polymerization. This is after polymerization. We remove the glycerin gel. We can see the extra bonding agent is flowing out, and we'll be able to remove them by using the blade or the diamond burr. So in order to achieve successful immediate dentin sealing, this that 10 little tips for your reminder is we have to, first of all, if we're doing this to the root canal treated tooth, we want to use glass ionomer cement to do the barrier, because there are a lot of root canal sealer, they actually contain eugenol, and the eugenol will affect the polymerization. So we can use glass ionomer cement to build up a base or liner around the orifice, so we don't need to worry the eugenol will affect the polymerization of bonding agent. Second of all, we have to prepare the dentin freshly and remove all the contamination material and to create a fresh, clean surface before we do the immediate dentin sealing. And then we apply the adhesive to seal the exposed dentin. So basically, this procedure is for dentin. So we don't need to apply all over the tooth, just apply to the dentin. And after we apply the bonding agent, we don't do air thinning because we don't want to have any oil or any contaminants from the air spray. And for some tooth, we actually can use composite, maybe flowable composite or regular composite material to build up a core or just do a liner or base to improve the morphology of the tooth we been prepared or elevate the deep margin. We'll talk about deep margin elevation later. And also we want to use the glass syringe to block the air to minimize the inhibition layer after polymerization. And after we do the polymerization, we would like to refinish the enamel surface. You use the hand instrument or diamond burr to finish the enamel surface, remove the bonding agent from the enamel surface. And we can gently just use pumice powder to clean the surface and clean the remains contaminants or the oil from the air or the water. And before we do the provisional restoration, we can actually use Vaseline to prepare the surface. And so we don't need to worry the provisional material will stick on the dentin surface. And before we deliver it, we just have to remember to use our air, like a sandblast thing to clean the surface, so we can remove all the debris or contaminants from the tooth surface before we deliver the final restoration. And then goes to the teeth preparation, because doing the online tooth preparation is very different from the traditional prosthesis. The consideration that we have to know when we're doing the online preparation, that's a lot, and it's all based on my experience. Can be affected by the caries location, can be by the remaining sound tooth structure, also the enamel surface and the margin placement, also the path of insertion, and we also have to consider the material thickness, because we have to have enough thickness for the material strength. And we don't want to have any sharp line angle remaining. It might cause too much stress on restoration. And clinical retention is more for the traditional prosthesis, but for the bone porcelain restoration, it's not so critical, but sometimes we still have to consider it. The retention form for bone porcelain restoration basically is the micromechanical retention, because it's mostly from the bonding strength. And the chemical bonding, we might rely on that because we need chemical bond to increase the bonding between composite resin and the porcelain. And the conventional retention form mostly is not very critical, but we do need it sometimes. And I will show you some case later on. The caries location is very common to be ignored when the caries happen in proximal, especially start from the beginning. And you can choose to cover the proximal surface if you see proximal caries, or you can choose to restore this caries by the composite before you put a restoration. It really depends how you want to design your restoration. But just have to be careful when you check out if the tooth have the proximal caries. And also, so like this case, the patient have mesial and distal proximal caries. So we can kind of understand the patient. It's very easy to get proximal caries. So I'd rather just choose to have proximal surface covered by the restoration. That's why I prepare the proximal surface. And this is another case, have a deep caries end up near root canal. The proximal caries is not too bad, but you can still see it on the X-ray on the mesial surface. So after I prepare the tooth, and then you can see the caries better. So that's then we will be able to check all the surface and find out more caries to remove and build up the surface, the missing structure by the composite material. So it's not so easy to identify the proximal caries. That's why when we're doing a preparation, we really have to be very careful about the proximal caries. This is after I restore the cavity by composite. And this is another case. The patient have the tooth number 27 near root canal, but you can see from the X-ray on the left side, the distal wall get very thin. So the X-ray on the right side, you can see the different angle after root canal. The distal wall still remaining very thin. So we know the structure is not very strong. Okay, so when we do the preparation, we really have to check out this wall if this wall is strong enough to support the occlusal force. So after we remove the remaining composite restoration, we found that the distal wall is way too thin. So we decide to just remove all the distal wall because we don't want to have any unsupportive structure remaining. There might be the failure reason might cause a failure. So I decide to remove all the distal wall. And this is a preparation of my design. And this is my final restoration. I still keep the palatal cusp because you can see the palatal cusp is very solid. It's strong enough. That's why I decided to keep it. And this is isolation before we do the final cementation. And this after we do the cementation. And this after we remove the rubber dam. You can really tell where the finished margin is. So with the porcelain, you do have very good aesthetic results. And sometimes we have, caries from all different surfaces may make us more difficult to think how to prepare the tooth. This patient have proximal caries on both sides and also have cervical caries. So I just don't feel comfortable about this patient's oral hygiene. I decide to make a restoration, basically cover all the surface that she got caries, except the lingual surface. So you can see the preparation, I preserve the palatal cusp, but I prepare all other surfaces. But from the buccal view, you can see I didn't do that much reduction on the buccal surface because I would like to try to preserve more enamel to provide better bonding strength. And this is the cementation after we deliver this porcelain only. So look at the skeletal structure. It's very important to have a good to structural remain to support our porcelain only. If the skeletal structure is less than 1 millimeter, or even after build up the wall is less than 2 millimeter, I prefer to have a cusp coverage because this is an area I have to bear a lot of occlusal force. So any unsupported tooth structure, we recommend you remove them because you don't want to take any risk to have this cusp fracture after you deliver the onlay. And also you have to check out the crack line very carefully. Like this case, patient came with a deep caries and have distal lingual cusp fracture. So we remove his composite restoration and still have some caries underneath. Okay, you can see this is right after I remove all the composite restoration he had. So I build up the missing structure with composite. And when I start preparing the tooth, I found on the distal, on the mesolingual cusp, there's a crack line around cervical area. I don't feel comfortable to leave the crack line there. And also the lingual will get very thin after remove all the caries. So just be safe. I decide to prepare the lingual cusp, cover it with restoration, which I can feel more comfortable after I deliver the porcelain only. This is a occlusal view after we deliver the only. And when we do the only preparation, we also want to try to keep as much enamel as possible because enamel bonding strength is actually much higher than dentin bonding strength. So for a lot of cases, I try to take advantage of the enamel to increase the bonding from the enamel, also enhance the retention of the restoration. So like this tooth number 25 have existing large composite restoration with another distal caries. And you can see on the right side, there's not much tooth structure remains after we remove all the caries. I decide to do the full coverage crown, but still try to be more conservative because you can see the buccal lingual cusp getting very thin. So I still use the dulcium disilicate material because they have good aesthetic result. And I prepare my margin super gingerly so I can preserve as much tooth structure as I can. And just try to save some enamel from the buccal and the lingual surface. This is after cementation. You can see from the buccal surface, even the margins is supergingivally, and you don't really see that. So we still can achieve very aesthetic result. Or like this case, the tooth number 27 have a deep caries and fracture. But luckily, he still have some enamel remaining, but he got very short teeth. So the restoration we can offer is trying to take advantage of the enamel structure and just have a lot of bonding strength from the enamel. So in order to get more retention, I slightly prepare the buccal cusp. You can see better from the cast is the margin we designed is basically just half of the cusp, and just do some occlusal reduction to provide some space for the material. And this is the day when we do the delivery. We are able to do a nice isolation on this tooth. And this is after we cement the onlay. So the margin actually placements really affect by the caries location. And it's also affected by our aesthetic concern. If you have some teeth, they could be seen and they're more in the front, we really have to think about how to design the margin so they can have better aesthetic result. And also the deep margin elevation is being taught broadly when you're doing the bound porcelain. Because when we have a lot of cases with a proximal caries or deep caries, they actually make the margin of restoration get very deep, and it's very hard to take impression or design the prosthesis. So what we do is we try to use the composite restoration to build up some composite and to bring the margin gingerly like 1 to 2 millimeter. So on the picture, you can see the bottom. We try to get a good isolation at the margin. It's located very deeply, and we adapt the band nicely, and we use a composite to bring the margin higher in order for us to make the preparation impression easier. So the advantage of doing the margin elevation is we can take impression easier. If you have tried to take impression on a subgingival piece preparation, you know how difficult it is to isolate the tooth or to dry the tooth will take impression. So it does make an impression much easier. And also it's easier for us to do the isolation because now everything is super gingival. And when we do isolation and cementation, it does get a lot of benefits. Also, when we have margin higher, we can have better light transmission. So we don't worry about the polymerization is enough, or we can actually control the stress better. And also because of doing that, a lot of cases we can avoid crown lengthening procedure. Because sometimes when margin is too deep in the traditional prosthesis, we really have to do the crown lengthening procedure in order to expose the margin better. So this article in 2016, they do show you the tissue response to deep margin elevation. After the deep margin elevation, even the restoration is bounded so deeply, even very close to the biological position. but still doesn't really affect the periodontal tissue, and still the periodontal tissues can still remain healthy. So we actually can avoid the crown-lengthening procedure by doing that. So it's even an acceptable concept for the periodontal concept. And the criteria to get a successful demodular innovation is we need to have very good isolation, because all the bonding procedure need very good isolation. And we need to have very good visible and clean working site, so we will be able to see the margin nicely when we're doing all the procedure. And we need to have a good access of light, so we can polymerize the bonding agent or the composite completely. This is the picture when we're doing a demodular innovation. After we isolate the tooth by the roller dam, and we have to place the band nicely, put a wedge to make sure the band can contact with the tooth surface nicely. We're doing a procedure, etching, rinse out, apply primer and bonding, and apply the composite restoration to bring the margin super gingerly. So the demodular innovation procedure actually does get a lot of benefit for us to restore the teeth. And the next, I'm gonna talk about minimum tooth structure, what we can do about it. Still rely on this bonding procedure. When some tooth with very minimum tooth structure, what we can do, is that gonna work? These tooths have an existing porcelain fused to metal crown, just have cavity underneath, so we have to remove that. And you can see this tooth number 37 after we remove the crown and the caries. The tooth structure is just so minimal. So this is my preparation after I do the caries control, build a composite core. What I can do is I try to preserve the enamel. I don't prepare on the enamel too much. And I try to increase very minimum axial wall to give some mechanical retention. And also before I was trying to do it, and I placed in temporary crown for a couple months and it lasts. So I decided to go for it. And this is another case, have the two porcelain fused to metal crown has problems. So we have to remove them, redo the root canal, and remove the caries. And this is actually after we finish the root canal. And this is teeth preparation after we remove all the caries, and also the core build up on tooth number 36. And you can see tooth number 37 with very minimum tooth structure. But I still try to follow the principle. I try to just preserve the enamel if I can, very minimum enamel. And I try to gain the axial walls to get some mechanical retention for restoration. And I did it then immediate dentin sealing to increase the bond strength for this case. And this is the cementation of the crown. You can see tooth number 37 have very minimum tooth structure remaining, but the crown still stay in the mouth for more than 10 years. Very similar case, big caries, and still we don't have much structure, especially on buccal cusp. So we preserve the enamel, we try to gain axial walls on our preparation. And can we crown the mouth for a month or two? The temporary cement still remaining, so we know the design works. So this is the bonding restoration we provide. I think it relies on the bond strength, also rely on the teeth preparation. This is after cementation. Okay, the crown, it's been last for 10 years too. Okay, now we're gonna talk about impression. Impression is really critical procedure, and for bond porcelain restoration, we recommend PVC impression material. And the ideal properties for PVC impression material is they have very nice flow behavior, so we can catch all the detail of our teeth, and they have very viscoelastic property and solid after the material is steady, and they have hydrophilic properties. So when we work on the mouth, we don't get too much trouble. An impression technique, basically, there are two different kind of techniques. One is we just doing one stage, or we can do two-stage impression. So for one-stage impression, we apply the live body on the tooth we prepare, because there's very low viscosity, so it's flow nicely. And after we apply the material, I would like to use air gently, just blow the material into all the teeth detail, and just use a putty to take impression. And this is the result after I use a one-stage impression technique. You can see the live body can fuse to the putty nicely and catch all the detail of the teeth. And with a two-stage impression, usually you can use some cases you has more units. So what we did is we take impression with the putty first, and after the material is set, we use knife to remove the material from the undercut and all the details. And we apply the live body again on the putty impression material and on the teeth, and we take impression. So as you make the multiple unit work become less stressful, because when you have to work on multiple units, you do have more stress to do the isolation. So you can use do the two-stage impression. And also the path of insertion is very different when you prepare bond porcelain restoration, because it can be from all different directions. And when you're doing veneer, you can also just insert it from buccal surface. Also, when you have tooth with different alignment, you can design a path of insertion by rotate the restoration into the position. And also when you have adjacent teeth, have proximal caries, you can do some adjustment to help you to get better path of insertion. That's very different from the traditional prosthesis. The material thickness usually is recommended up to actually higher than 1.5 millimeter, but it's more concerned on the buccal surface. So when you're just doing a veneer, it's not involved the occlusal surface, you can have less reduction on the non-occlusal surface. And when you bond the porcelain on the enamel, actually you have less thickness requirements. But if you bond on the dentin, you definitely need more thickness. It's recommend up to higher than 1.5 millimeter. And then isolation is very critical to bond porcelain restoration. I can't really address too much on this topic because it would be another long story. But what we usually use is rubber dam, of course, and we can use gingival retraction cords. And now a lot of people, they use Teflon tape instead because there's less fiber, and it's very cheap, and it's very easy to handle. And for multiple unique cases, I like to use Updragate. It's a product from Evoclear. So this is a veneer case before cementation. I like to use a Teflon tape as a retraction cord to retract the gingival margin. And this is Updragate I use for multiple cases. Cementation is a very complicated procedure. And also involve a lot of material. We use hydrophosphoric acid for porcelain. We need a phosphoric acid for enamel. And we need ceramic coupling agent, which is silent, to increase the chemical bonding between the porcelain and the resin. And we use the bonding agent, of course. And we can use dual Q resin cement for cementation. We can also use flowable composite or regular composite for cementation. It really depends on personal privilege because everybody's different. And to surface, we require sandblast. This is a sandblast I used before cement only. I used to clean the tooth surface. And also you require porcelain polish kit because a lot of adjustments after you do cementation. So you will need to polish the porcelain surface after you cement the onlay. The porcelain treatment before we deliver the porcelain restoration, we have to use hydrophosphoric acid to etch the porcelain surface. It really depends on what kind of ceramic you're using. You have to read the instruction. And then after that, you clean out the hydrophosphoric acid. You clean the restoration in 75% alcohol in an ultrasonic cleaning machine to remove the fragile particles that come out from the etching. And then you apply the sealant on the porcelain surface to provide a chemical bond between porcelain and resin. And so the sealant is very important to create stronger bonding between porcelain and the resin. So this is how you etch the porcelain surface. And after you etch the porcelain surface, you can see the surface become rough, like a foggy looking surface. And then you use the 75% alcohol to soak this restoration for 3 minutes to remove the fragile remaining particles on the porcelain surface. And then you apply sealant on the porcelain surface. And after you apply the sealant, the heat treatment is required. Basically, we apply the heat on the sealant. So we remove the multiple layer of sealant molecule to increase the chemical bond strength. You can use blow dryer or oven. This has been mentioned by Dr. Pascal McNee. And I like to use like machine because it generates heat too, and also very easy to get. And the cementation, you can either use the dual Q resin cement, which is easier to handle, but usually they have a higher stain rate compared with a composite resin. But it has a benefit for some case if it's very hard to polymerize some area of the tooth. Or you can cement the restoration by composite resin. You can either warm up the composite or use ultrasonic instrument to seat to increase the flowability of the composite. So you'll be able to insert the restoration into the position. And ultrasonic instrument also help you to vibrate the composite resin. So the tip on the left is the tip help you to seating the onlay into the position. And polymerization, we recommend use the brass band spectrum curing light, so you will be able to have a higher convergence rate of the resin. So the high degree of monomer convergence is vital to enhance the physical and mechanical properties, including the color stability, biocompatibility. And so it's really, we really recommend you use the brass band spectral curing light to get a higher degree of monomer convergence. And for the tooth surface, before we deliver restoration, we can use a pumice powder to clean the surface, or if you have sandblast, it's more efficient. We can use sandblast to clean the tooth surface. And we do the selective etching, basically just on the enamel surface. And we apply the bonding agent on enamel. So like this inlay is being prepared. This is a tooth surface. We do the isolation. And we etch the porcelain, prepare the porcelain, and prepare the tooth surface, and after cementation. So there's a lot of procedure involved during cementation and get very critical about it. That's why bond porcelain procedure is very technique sensitive. And the last part of this topic is we're going to talk about diagnosis. It's very important for actually most of the cases. We have to do better diagnosis, try to realize the etiology of this case, and try to analyze the occlusal status so we can achieve a better result, have long-term success. The patient comes with a cusp fracture. If you think it's just a caries and cause a cusp fracture, you could end up, you have to redo the case again. Because if you look at his teeth, he have very strong upper parietal cusp, which cause a lot of force on this lower molar. And also because the patient doesn't have very good anterior guidance. So that's why it causes a lot of force on this second molar. So in order to achieve better result, we actually, after we do the teeth preparation, we do some occlusal adjustment on upper molar to short the cusp height, and we deliver the crown, the porcelain onlay, and just do the selective edge and insert the final restoration, and do the occlusal adjustment, make sure there's no extra lateral force on the molar. If we don't do the adjustment, we might have the porcelain onlay fracture again. This is another case. Patient had slightly open bite, but she come with the same problem. She had all her molars have porcelain, have all the amalgam filling came off, composite filling chip off, and it's very sensitive. and we figure her occlusal loading is fully on her molars. So we decide to give her a better anterior occlusion to have anterior guidance, and with a little bit of liner treatment. And after that, we start prepare the teeth and remove all the caries and deliver the onlay on the 4 lower molars. And after delivery, we just have to make sure there's no lateral force on the molars to prevent the problem happen again. So there's much less dispersion loading on the molars. At the beginning, you can see a lot of loading on the molars, and that's teeth preparation and our onlay trying. So when we adjust occlusion, we try to have less dispersion force on the molars. And this is the last case I'm gonna talk about today. It's a very extreme case. The patient had very bad attrition and erosion problem, and she can never change her diet. So at 2010, she decided to have 6 veneer done on her upper front teeth. And like 8 years later, because she still have a porcelain problem, and she still can't change her diet. So you can, it's not very clear, but on her upper veneers, there are a couple enamel chips. We try to fix them on tooth number 11, tooth number 12, tooth number 23. We actually repair the veneer by composite. So this is 8 years after. But the worst problem is if you look at her occlusal surface and the lingual surface of all the teeth, the erosion problem just get really bad. So in order to preserve motor structure, we decide to replace the 6 veneers and try to cover the lingual surface by some veneer or composite restoration. So the treatment plan is we do the buccal and palatal veneers on upper anterior teeth, and to replace her old crowns on number 17, 16, and 27. And we use composite restoration to cover the erosion occlusal and palatal surface. And tooth number 36, we use direct composite to restore the occlusal surface. And we design the tooth by increase the vertical dimension a little bit. And we take a bite after increase the vertical dimension, and we do the wax up, and we put the temporary crowns on tooth number 16, 17, 27. And we do the composite restoration, and we do a temporary veneer on this upper front teeth. And so basically we have her occlusion the first visit. And this is the temporary veneer. She's been worn for a month. You can see that it functions okay, not very good hygiene, but look not bad. And she is functioning with it without any problem. And you can see the palatal surface has been covered by the temporary restoration or composite restoration. So after we've been trying this occlusion for a month or 2, she had no problem. So we decided to take a final impression. You can see the preparation of that as we didn't really prepare that much, and we just tried to remove all the old veneers and not too much preparation on her parietal surface. And we took impression for the upper 6 teeth and 3 posterior teeth. And this is master cast at the first impression. So we use it to fabricate the parietal veneer. And that's so tiny, so you have to handle them very carefully. And this is the day when we deliver the parietal veneer, and this is after we deliver the parietal veneer. And we take another impression for buccal veneers. Okay, this is master cast for upper veneers. And you can see still a lot of enamel remaining. We don't like to remove the structure. And this is the day we deliver the buccal veneer. This is the day right after we put a buccal veneer. The patient is happy with the result. The soft tissue get better after 2 weeks. You can see the papilla is adapting the veneer nicely. And the patient will have the problem solved without removing too much tooth structure. That's why she's been holding the treatment for years, because she doesn't like to remove tooth structure. And I'm happy the bound porcelain restoration will be able to achieve the result and achieve patient's expectation. Okay, thank you very much.